Well, thank you so much for that wonderful introduction, Raphael, and thanks to all of you here online. I have a special place in my heart for your institution, for New York. I grew up on the other end of the state. My brother still lives in Queens, and certainly have had the opportunity to work with many faculty at Mount Sinai, as well as knowing it kind of as one of the places where occupational environmental medicine and sarcoidosis, the two areas I focus on, really had some of their origins. So I just have my disclosures here that will not impact our talk, and our objectives really to walk through some of the known causes of granulomatous disease, taking a few moments to focus on a couple near and dear to my heart: chronic beryllium disease, where I have continued to focus and started my clinical and research practice, as well as hypersensitivity pneumonitis, and talking about sarcoidosis and really trying to drill down on what are some of the drivers that may be causing or implicated in sarcoidosis risk, and then how we're kind of looking at these three different diseases or a number of diseases to let us think through some next steps that we can help move forward the field. So as an occupational environmental pulmonologist, my job, or I feel like my job always, is to consider, the black side of disease and what we don't know what the causes are, and try to continue to move them over onto the known causes. And for some of you who may not be aware of it, chronic beryllium disease, which results from exposure to beryllium, used to be called sarcoidosis. And so, again, it wasn't until we realized that it actually was beryllium causing this outbreak of clusters of cells that we started to differentiate it. And so I want to start off with a case presentation. This is a case that I saw a few years ago now, a 66-year-old who came in with what he was told was sarcoidosis, hyaluradenopathy, small nodules, and actually it had a bronchoscopy of this CT scan, which showed granulomas in the parenchyma. He had shortness of breath with exertion and cough. He told me he had worked at a Department of Energy facility where they make nuclear weapons and was concerned about whether his disease was related to his work exposures. His physical exam showed a little bit of wheezing. We got lung function. It was mildly abnormal with a low FVC. Again, for a worker, his TLC, FVC were also lower than we usually see in folks with a healthy worker effect, and his DLCO was normal. And actually, that was reflected when we got him on an exercise bike, which we do frequently, and measured his arterial gas. While he had normal capacity, his oxygen levels, and again, you have to remember, I'm in a Mile High City here, were normal at rest, but they did fall, not rise, and his AA gradient rose too, suggesting that there was a gas exchange abnormality. So again, because he's in my clinic, we got some additional history, and he had worked in a nuclear weapons site. You can see our beautiful mountains here, where he was a maintenance mechanic, and he was all over the site. This is Rocky Flats. This was a production facility for the Department of Energy to make nuclear weapons, as well as the beryllium triggerhead. It is now a nature preserve. We can talk about that another day. Here's one of the machines, and most of the time folks weren't wearing respirators, many of them not even coveralls. He certainly knew that there was beryllium in this facility, and he was involved in the decontamination and deconstruction when they tore down the facility. Like many other folks, he moved to another DOE site and was found to have an abnormal chest x-ray during medical surveillance and sent to us. Our additional testing, well, we did another bronchoscopy because we wanted to see if he had evidence of something called beryllium sensitization. What we found was he had alveolitis. He had a high number of white cells in his lungs and 33% lymphocytes. That's elevated. His lymphocyte proliferation test to beryllium was abnormal, as was his blood. And his diagnosis: chronic beryllium disease. This allowed him to be eligible for Department of Labor diagnosis of chronic beryllium disease, which includes $150,000 for some folks who have worked directly at a facility, as well as medical benefits. And so we counseled him about making sure he was applying for those benefits, gave him an inhaler with inhaled corticosteroids, and did some main recommendation just from a health maintenance standpoint, and had him come back to clinic. And so it's just always important to remind folks, maybe fewer in this group than some of the pulmonologists I talked to, that not all granulomas are sarcoidosis. And chronic beryllium disease is one that I spend half of my time, as Raphael said, evaluating. Hypersensitivity pneumonitis, near and dear to your heart, World Trade Center sarcoidosis, as well as many other exposures and or diagnoses. And again, it's really important to ask about people's jobs or even their families' jobs, and to think about the case that you're seeing. You know, in general, we always remind our trainees, whether they're our pulmonary trainees or our occupational medicine trainees, that this is kind of a two-pronged approach. Not only do we have to think about what diagnosis we have in the lung diseases, asthma, lung cancer, interstitial lung diseases we're talking about, and what are the exposures, and can we link them, and are there additional testing, or is there additional testing that's needed? So again, environmental history is always important. I love the story that one of my colleagues shares, that she was on the phone, couldn't figure out the cause of a gentleman's hypersensitivity pneumonitis, and then heard the bird in the background. And so again, knowing what people are doing outside of work is also incredibly important. And yet what they're doing at work, who they're standing next to at work, what they might do part of the time, or even what they've done in the past for many of our beryllium workers, as well as other workers, is very important. And so just if some of you aren't aware, beryllium is used in a number of applications. It really became known as a health effect because of its use in the nuclear weapons industry back in the early 40s, late 30s. However, it's used all over the place. This is the James Webb Telescope that we had the opportunity of working with folks across the country as they were machining these beryllium mirrors, $1 million each, and now it's up in space. Certainly, Air Force is a group that's also at risk, as we know that a lot of the aircraft and defense industry has exposures, including in helicopters. One people don't think about is sandblasting of large ships, and that has been known. We also know nuclear reactors are a problem, and non-sparking tools, as well as a number of other applications. So again, asking somebody even the simple question of, do you work with metals and or do you work with exotic metals, is an important question. So what do we know about exposure to beryllium? Well, what we know is that people really, as in other situations, have two primary sources of exposure. Inhalation is the biggest one. When people are involved in machining, even this guy who's using computer-based machining, when he opens up the doors, those very, very small particles, micron level, are able to get deep into the lung. The other place is that a lot of workers in the past especially, but even ongoing, don't wear gloves, and so skin contact happens. And we do think that some of sensitization starts actually with skin exposures. And again, we also know there's a lot of problems with dusty work areas and bystander exposure. As far as health effects, most beryllium workers do not get any health effects. However, a larger number, kind of the inverse here, is that people can develop an immune-mediated mechanism that seems to primarily be limited to the lung, called beryllium sensitization. We take people's blood cells, we separate them, we add beryllium, and they divide. This is a clinical test that now is required under the Department of Energy from our federal government for workers there, as well as in OSHA for medical surveillance of beryllium exposed workplaces. We know that the people with sensitization don't have lung disease, and that there are groups of people that we will identify with sensitization who may go on to develop the granulomatous disease, chronic beryllium disease. And sometimes people present right away with chronic beryllium disease, as our patient did. So we've been studying the beryllium immune response and trying to understand it for many decades now. And one of the things that we and others have found is that there is this very strong genetic marker. There's an HLA, that's the part of the immune response that helps us determine self and non-self and respond to foreign invaders. And it's a class 2 HLA DPB1 with glutamic acid at amino acid position 69. It's what we call a supratypic marker. It's found in many of these HLA DPB1 molecules that is present in the vast majority of people with sensitization and disease. It doesn't differentiate those that have sensitization and disease. And over time, what we've realized is that this variant changes the conformation in the setting of beryllium to respond to an antigen and result in that proliferative response. We recently published a GWAS showing, again, a very, very high P to the greater than minus 60 for this marker. And what you can see is we didn't find a whole lot of other genetic variants. Now, some of this could be our sample size. This is a rare disease, and we had about 500 people that were from across the country. But so far, we have not been able to detect variants that help us differentiate those who have sensitization or disease. However, one thing that we were able to publish early on, Mike Van Dyke, who's now faculty at CSU, was a PhD candidate in our group. And we were looking at exposures and the interaction with the genetics. And again, if you think about regulation, we want to regulate the most highly susceptible. And what we found was in chronic beryllium disease, not sensitization, that the probability increased with increasing exposure. And we found that that varied by the type of GLU69. People who had 2 copies had the highest risk. People who had none had the lowest risk, and there were a number of others in between. Now, at the time we wrote this paper, the OSHA standard was 2 micrograms per meter cubed. It is now 0.2, which was what the Department of Energy was. So this was some data that OSHA used to help regulate beryllium exposures and really implement the use of the LPT as medical surveillance in the workplace. Now, again, we know that exposure matters. I just showed you that, but here's a bit of other data from some workplaces. Here's a workplace where we implemented medical surveillance one time, high exposure. We found a very high prevalence overall of 15% of CVD and sensitization and almost half and half. Another facility we continue to follow, 10% overall, and they've shown over time that some of these people here with sensitization may go on to develop disease. Those are the progressors. And you can find beryllium in very, very low exposure settings and predominantly sensitization. So again, this is where the exposure matters. And I think this probably is relevant to other granulomatous diseases. And again, I'm just showing this in another paper we published a few years ago. Now, because of our referral center, we see a lot of folks with sarcoidosis who've actually had beryllium exposure. And Anise Maier, who is an occupational physician in our group, now professor emeritus, looked at these folks and said, what is the difference if we see people that we cannot call chronic beryllium disease? They have normal lymphocyte proliferation tests. What do we see as different? Well, we do tend to find that more of those people have granulomas on biopsy. They have lower BAL lymphocytes. In our population, they had lower lung function and more likely to have abnormal chest x-rays and more likely to be a more severe manifestation. This is a sarcoidosis staging system where 0 and 1, this is just lymph nodes, 0 normal, 2 with abnormalities in the lung, 3 no lymph nodes, this 2 has lymph nodes, and 4 is scarring. So again, we found these differences and we found no cases of extrapulmonary disease. Interestingly, a group from Germany recently published a similar clinical population, not a workplace population like ours was, and they found that their CVD cases had lower lung function, more restrictive, and their chest x-rays were no different. They found extrapulmonary disease present in their CVD cases, and again, maybe this is a difference that when you have clinically manifest disease versus disease that has problems, that you're going to end up with more of severe disease. And, in general, we don't find a lot of extrapulmonary disease. But again, maybe this is an issue of exposure amounts, types, as well as maybe some genetics. Sorry, my mouse just did something funny. Okay, so if we look at the clinical differences just kind of as a snapshot, if you see a patient in clinic in general, if you see something like some skin disease, erythema nodosum, lupus pernio, we don't see that in beryllium disease. We do see these nodules. We do tend to see a more insidious onset. We don't see neurologic disease, and I have not seen that reported. Cardiac is very rare, hepatic occasional, and there have been a few case reports recently, or one case report of hepatic and one of kidney. So again, that's a big point, and there's a nice guidelines from the ATS that helps go through this. It also goes through the diagnostic criteria, which do differ depending on where somebody worked. For OSHA, there is a real more conventional and clinical, and what we use, a sense of what causes sensitization. You've got to have more than one test. The Department of Labor and Department of Energy does not require that. People can get medical benefits with one abnormal lymphocyte proliferation test. The requirements for chronic beryllium disease are pretty similar. The Department of Labor does accept sarcoidosis as a diagnostically covered in the right setting. And so again, those people can get medical benefits. People who are part of Part B get this additional $150,000. They also get money for an impairment rating. And again, this is just was in our local newspaper. I heard from the government, yeah, dear, your compensation check is in the mail. And unfortunately, we have seen that with a lot of Department of Energy and our Rocky Flats workers who didn't get compensated while they were still alive. And I just have to point out, we have seen and continue to see occasional community or familial cases. This is a facility in Reading, Pennsylvania, one that I know folks at Hopkins have continued to see some cases after our publication many years ago, where the facility was right here in the middle of the city. And there were a number of family members who ended up with either chronic beryllium disease, and there were a couple cases of sensitization, which we don't know what happened. But again, always important to ask what's going on in your community too. And certainly you all know that with case clusters of World Trade Center sarcoidosis that I think have been nicely described by in the FDNY, but also in your responder program with some dose response. And we worked with David Prezant and the FDNY. We actually did beryllium testing because small levels of beryllium were found in the debris, and we have not found one case. So again, this is not chronic beryllium disease that you folks are seeing. We know Carrie Henna included us in a nice publication looking at what was happening with the sarcoidosis cases after 15 years. Similar incidence rate actually to what we see in sarcoidosis in the community at large. Some did have radiographic resolution. This is a contrast in firefighters that David had presented earlier, who had even a higher number. The interesting part is that it seems like over time we were ending up with more multi-organ involvement. So really what looks more like sarcoidosis in these groups. And again, the health registry showed the same thing. So I'm going to switch gears a little bit, present a real live case here. 17-year-old kiddo who came to me with dyspnea, dry cough, which developed 1 week after his school had ended. He had been diagnosed with sarcoidosis and came actually for treatment. He had developed fever, night sweats, chills, and weight loss. We do see this on occasion with sarcoidosis, but it's not as common. We also see it with beryllium disease. He reported that 3 months after school had ended, he had gotten a number of courses of antibiotics and really hadn't improved, had this bronchoscopic biopsy with these poorly formed granulomas, which made me raise my eyebrows. In general, sarcoidosis has well formed, and he really didn't have any history that I could find, except that when he was at home after school was out, he wasn't involved in sports, and he was using the hot tub in his parents' room and even submerging himself to the point where his nose was right above the water and pulling the top over his head. So again, this to me was hot tub lung, and you'll see nicely that his CT markedly improved when he was out of exposure. And this is hypersensitivity pneumonitis. This is an exposure, and there are many organic exposures that can cause a granulomatous process, microbial, plant, animal. There are some inorganic, some chemicals to consider: isocyanides, anhydrides, some drugs, and methacrylate is an important one. There's also potentially components in resins, foams, so important to ask about it. We were involved with a ATS document, which actually does say you do need to get an exposure history. They start off with their paradigm for how to make a diagnosis with a CT scan. Is it typical for hypersensitivity? Potentially consistent or not compatible, and really do think that it's important to take an exposure history and go down to being able to make this diagnosis potentially without a biopsy, which I think is helpful. So I'm going to refer you to that document. And then switch to our sarcoidosis piece, because I want to spend some time, since this is where I'm spending more of my time really trying to continue to understand this disease better. So sarcoidosis is a diagnosis of exclusion. Again, we see these well-formed granulomas that we also see in chronic beryllium disease. There was an expert opinion in 1999, which I was involved in, and came out in 2020, just as the pandemic hit in April of 2020. And initially, everybody thought that we needed to get a biopsy, and we redid our guidelines and said you need a compatible clinical presentation. If you get a biopsy, you should, for example, consider an ultrasound-guided endobronchial biopsy instead of putting people through an open lung biopsy. We went through and spent a lot of time. Adam Morgenthau from your institution was also involved in going through the differential diagnosis. And we have many, and this is probably the most complete one. So if you do come across a case and want to refer it, we've got many, many differential diagnoses by biopsy based on infection, exposures, malignancy, autoimmune diseases, as well as by organ to consider. Now, the reason I think sarcoidosis is important to talk about with you, all of you, is not only because we know that there are exposures that cause sarcoidosis-like disease, but I do think, and there are lots of data and evidence to date that suggests that sarcoidosis is an exposure-related disease. Andrew Fontenot, who used to be at the University of Colorado, and I were very close collaborators and had done a lot of work looking at beryllium as well as sarcoidosis and its immune response over the years. And we know that there are a lot of similarities, and that really what we understand about the immune response in sarcoidosis indicates that there is an exposure or likely exposures that are triggering this response. There is some exposure and likely antigen presenting cells, whether they're epithelial cells, something we're looking at even in beryllium to this date, or other cells like T cells and B cell macrophages, monocytes, dendritic cells that are then presenting an antigen of some form to T cell or and or B cell, and then start this immune response that results in inflammation, and eventually these cells, even if the lung is the original source of exposure, go out into the bloodstream, traffic to many other organs, including, for example, lymph nodes, perpetuate this immune response, and eventually go out into the organ involved, again, in beryllium disease, primarily coming back to the lung, causing that granulomatous inflammation. Again, that's why we can detect sensitization, as these cells may get their original exposure in the lung, but then other cells get through the lung and go out into the bloodstream, and that's what we're measuring. Now, interestingly, in sarcoidosis, we know that there's a variety of immune responses. Some people have these exposures, we think, just like in beryllium disease, and never develop any problem, the majority of our beryllium exposed workers. However, some do develop this abnormal immune response, which we also know is driven by HLA variants, this part of our body that helps us respond to foreign substances, albeit different ones, and that immune response can become abnormal. In some people, they may demonstrate early stages of sarcoidosis and then have resolution. Others may go on to have persistent or even severe disease. And unfortunately, end-stage lung disease and fibrosis still is the primary cause of death in patients with sarcoidosis. And so this abnormal immune response, the reason that some people have resolution versus progression or persistence of disease, has been an area of focus in our group on a number of levels. And I'll talk about some of those. So there are a number of clinical risk factors for disease that I also think implicate exposures. First of all, men and women have a difference in their risk. Women have a much higher risk than men in general. There may be some differences. For example, in cardiac disease, men may have a higher risk. That may be because of exposures. We also know that unlike a lot of other diseases, this happens to people in the prime of their life. This is the ACCESS study that was an NIH-funded study conducted now many years ago, showing this peak in people who are working and potentially exposed to things around them very early on. We now know that there's actually a second peak here in the 60s. And interestingly, it happens more so in women. And that's in contrast to many autoimmune diseases that happen more frequently in older populations in men. This also differs by race and gender, as I just told you. We know that Black individuals also overall have a much greater risk than those individuals of European or white ancestry for sarcoidosis. I'm showing you a picture here of the Women's Health Study, Yvette Coger, who's an epidemiologist at BU, conducted on Black individuals, showing the much higher rate in individuals of Black ancestry and also in women. 2% lifetime risk. Hormones likely play a role, as I just mentioned, increased risk in women in the post-menopausal time, as well with studies that suggest that weight gain and obesity may also be drivers. There's geographic differences. If you grew up in the Northeast, you have a much greater risk of having or live there now sarcoidosis, and if you live in a rural versus an urban setting, again, implicating exposures. There have long been known seasonal variations in sarcoidosis, and I'm showing you some studies from across the globe and across the timeline here. This is a group out of the Karolinska. Sweden has been known to have a very high rate of a certain type of sarcoidosis, and they have always found this increase in the springtime. There may be a little bit of a hint of higher in the colder season here from the Mayo Clinic, certainly coming down a bit in the warmer season. And this study from across the UK, the US, Australia, also suggests an inverse where you're seeing higher levels, and again, Australia going the opposite way, in warmer season. And that was plotted here in a recent letter to the editor for the Blue Journal, showing, again, as temperatures higher, sarcoidosis risk is delayed but lower. And these authors theory that maybe some of this is related to NO2 and PM2.5 and show, again, that those actually do correlate. This has been an area of interest more recently, looking at air pollution and sarcoidosis. And certainly we know that air pollution exposures are exposures of disparities. So maybe they could help us understand the difference that we're finding in individuals who are at risk for this disease, including women and Black individuals. The first study that was done was published back in 2018, Cheryl Perosi at the University of Utah, that has a more predominantly white population, showed lower health-related quality of life with short-term PM2.5 exposures in individuals who were fibrotic. She didn't find lung function exposures, small study. Michelle Sharp and her group at Hopkins recently looked at this in their population in Baltimore. They looked at area deprivation index, which we know is well associated with nitric oxide and PM2.5 exposures, and found that individuals who are African Americans had worse NO2 and PM2.5, as well as worse ADI. Not a surprise. They also had lower lung function that Michelle did and her group found associated with NO2 and PM2.5. Jillian Gooby and their group, along with folks at the University of Pittsburgh, looked at this and recently published this article. And again, over here, you'll see looking at quartiles of exposures, changes in FEV1, FVC, and DLCO, which was the most predominant, found that people who had higher exposures in the Pennsylvania area had a lower lung function. Couldn't corroborate this in a Canadian population, albeit much lower, and found some differences in that their more fibrotic disease had higher air pollution markers, but so did some of their lower or kind of more normal lung chest x-ray findings. So we're starting to also look at this in our population where we see, for example, a lot more ozone, but also see a lot of problems with PM 2.5 and looking at some of these same components as well as other organ involvement to see if maybe this is playing a role, as we know that air pollution impacts, for example, neurologic disease, stroke, as well as cardiovascular disease. So I'm going to take a step back and talk about a study that was done many years ago. Again, this access case-controlled study that the NIH funded, where they really set out to define the etiology of sarcoidosis, and guess what? Didn't. And it was a matched case comparison study. Our group at National Jewish undertook very detailed exposure questionnaires and found some risk factors: musty odors, insecticides, air conditioner, birds, teaching, automobile manufacturing. In general, organic and inorganic exposures in the workplace. They found a decreased risk of tobacco smoke, which has been found in other situations, but not in all settings where it's been looked at. They also found some phenotypes associated with environment. And again, I always like to show this picture that genetics may load the gun, but the environment pulls the trigger. So again, this is this gene-environment interaction in sarcoidosis. We had the opportunity to look at a large mortality, the death certificate study, and 25 states previously, this is now only up to about 2,000, had a listing of people's last exposure. So we looked at 7 million deaths with more than 3,000 cases of sarcoidosis that were dying related to it, as well as another 15 due to sarcoidosis. And what we found was having any exposure, if somebody reported having a workplace exposure, there was a higher risk of dying from sarcoidosis, but it was really being driven by women, not men. We then looked, based on the studies that I've already showed you, at breaking this population down by women and men and by race as well. And we found some differences, some that were consistent across various groups. For example, working with metal was found in both African American as well as European, found in all the Black subjects, but in women and men. So was teaching, and yet teaching also, which has been found previously as an exposure, was found in some of the white subjects too. And then we found some that were just specific for women and just specific for men. So again, found that there were some exposures that were associated, and there are a number of others that have been found, and some consistency of data coming across. And I would refer you to this article that Nancy Lind, who's now faculty at Johns Hopkins, did as part of her practicum for her occupational environmental medicine training. And again, there are exposures. Musty odors to me is just mold, fungus, potentially even some bacteria, but we are finding again that there are many organic. Inorganic exposures are being found to some degree, but you'll see in our study, silica was actually lower risk. So if you worked in a silica industry, you had a lower risk. And yet there are inorganic substances such as metals. We theorize that some of the exposures, for example, that teachers might have, people working in personal services or other areas, childcare, might be due to or related to having a transmissible agent. There are studies suggesting, again, that the exposure varies by the genetics. So Courtney Montgomery and her group looked at different exposures in an African American ancestry population and even found a dose. individuals who had illuminant exposure and had a higher amount of African ancestry, if you will, had a higher risk for exposures to fish tanks, which again could be a mycobacterium surrogate, a lower risk. Sorry, I jumped ahead here. Trying to go back. There have been, again, exposures and a question about silicosis and inorganic agents. Again, I think there's very good data, and we'll talk a little bit in a minute about Cox postulates that World Trade Center, an inorganic substance, can cause sarcoidosis, and I think there's good data to support that. The question mark about silica, to me, is still very much a question. And so we know that silica exposure can cause a disease that can look like sarcoidosis, significant morbidity and mortality, a number of conditions, including autoimmune diseases. Jeremy Hua in our group recently published the study about something called silicosarcoidosis, where they found silicotic nodules as well as granulomas in some folks, as well as these X-ray findings in other people who didn't have biopsies. And I just want to talk quickly about engineered stone workers, because they have the opportunity for a lot of exposure, more than 90% free crystalline silica, very high rates of silicosis. And yet these look very much like sarcoidosis CTs, and that's the problem. Sarcoidosis and silicosis can look very, very similar. This was a large group in the publication that Jeremy put out last year. They can result in autoimmune diseases too. So I think there's a complexity about trying to understand silica exposure in sarcoidosis. The radiography can be indistinguishable, and oftentimes people don't get biopsies if someone's had silica exposure. Pathology is often not obtained. When we do in sarcoidosis, even people that I cannot find an exposure of silica, we can find birefringent material, and they use that as one of their criteria. The other question is, if we have silicotic nodules and we're finding granulomas, could it be that those are foreign body reactions? Or is this an HP-like reaction? There's a lot of other exposures, as I mentioned, including to resins and other substances that some of these people may have had, that maybe this is an HP and a silica response. For example, we sometimes see asbestosis in the setting of chronic beryllium disease. And the question always comes back, is it causative? Does it contribute or aggravate to the disease? And Nancy looked at this and I think did a really nice job of looking at Bradford's Hill's 9 criteria for causation. And again, I'll just go through quickly that the World Trade Center meets many of these. It meets strength of association, consistency, temporality, biological dose, plausibility, coherence, because we do find similar to sarcoidosis. We also find HLA variants. Experiment and specificity may not be as clear in the World Trade Center folks, but analogy also likely works. In silica, I don't think we're quite there. I just showed you some diseases, some disease studies of sarcoidosis where we didn't find consistency of the data, that the strength of the association is quite low, and the specificity and biological gradient. And the limited data really are present for experimental. Now, there are some folks that really think that this is causative, and I think it's possible it's contributing. It may be that silica can help ramp up this original immune response. Maybe another antigen then comes into play or exposure, and that eventually can result in sarcoidosis. So I think it's possible. I have a hard time being able to evaluate an individual. I've certainly said that it aggravates a case. And if there are, for example, silicotic nodules on a biopsy, then I think that's a different situation. Now, the issue is with sarcoidosis, and I think some of the trouble we've had finding a cause is maybe the antigen is gone. It is there originally, and then eventually it's other things like serum amyloid A, which has been studied at Hopkins, but also Adam Morgenthau has been trying to think about as a treatment approach. Could be what then is persistent, and that this immune response then is aberrant. I want to briefly touch on sarcoidosis in some other settings, we know that military folks have a very high rate of sarcoidosis. And Merdad Arjamandi at the VA in San Francisco, along with CETAMED, published this study now a couple of years ago showing this very high rate and the differences across the population. Men more than women in this population, unlike, women higher than men. And again, African Americans higher than European Americans or whites, similar to what we do see in other groups, and some differences across the US, Northeast again being the highest, also differences by the branch of service, with the highest here being Air Force or a combination. I just want you to, again, think about those pictures I showed you very early on with the Air Force, and knowing that a lot of folks that are in the Air Force have the potential for beryllium exposure. He also showed, or they also showed, that the rates are increasing over time, and predicting that it will continue to. So they actually looked at whether people were getting a beryllium lymphocyte proliferation test, and if possibly this could be beryllium disease. And first of all, a lot of the individuals in the service did not get a beryllium lymphocyte proliferation test. If you were white, or you were from the South, you were more likely to get it, one. We actually wrote a letter to the editor and said the GAO estimates that there are more than 100,000 aircraft maintenance workers. And so we actually estimated that there could be about 5,000 people within this group that have beryllium disease. Regardless, I think it's important when you see folks to make sure that they're aware of the PACT Act that actually does provide sarcoidosis as a covered entity at this time, especially for those folks that have been in post 9/11 deployment. Now, I mentioned before that we see differences in disease by race and gender. We also see differences in organ involvement, and this again comes back to the access study, Caucasians versus African Americans or European Americans now, men and women, and also by age. And I think that this just has implications for risks for phenotypes. I think many of us think that exposures likely are helping dictate the type of disease that people get. This is a study that we published many, many years ago showing these HLA variants and how they do differ based on, in general, different organ involvement, as well as the most notable, this Lofgren syndrome. It's an acute manifestation of sarcoidosis that actually in Sweden, if you have a DRB1 0301, you will virtually have resolving disease versus a 50-50 shot if you don't. It's used actually in clinical application in Scandinavia. So again, I think there's data to suggest that exposures might be what could predict this. Remember also I showed you that this is the group that tends to present more in the spring. And they looked at that in the access study, and they did find that looking at lung disease only, that wood burning, for example, was significantly associated with risk of having lung involvement in Black individuals versus whites. And they also found that a response here that is not significant in Black individuals, but actually protective and significant in whites. So a lot more work needs to be done, and large populations need to be done. We and others have published a few studies, but the consistency of the data is not quite there. So why have we failed to find some exposures that are causative? And I think it's because the exposures are complex. It's easy to measure, for example, genetics, which is why many of us have focused on those. First of all, sarcoidosis is likely many diseases with these different phenotypes. It's likely that it's a multi-hip hypothesis. We may have many different exposures, whether it's an infection along with other exposures, a repeated or one significant exposure. And I'm going to just reflect that what we know currently about beryllium disease also suggests that it may be that it's a hypersensitivity response. We've been contrasting and comparing what we're finding from a molecular standpoint in our beryllium patients and our sarcoidosis patients and trying to look at epigenetics. Again, epigenetics are these mechanisms, some of which we understand, some of which we don't, that seem to be important in regulating the immune system as well as gene expression, and in some individuals can be passed multi-generational. For example, the Dutch who were exposed to famine in World War II, and now their offspring have higher risk of diabetes. So we've been looking at epigenetic marks, methylation as one that actually dictates gene expression in general, also looking at how open some of the chromatin is and available. And what we found was if we look at the methylation levels in these genes that we know are very important in the immune response, that we see some similarities between beryllium disease and sarcoidosis. Here are some that are lower, with sensitization being the highest. And these in general are more expressed genes. And here are some where genes can be shut off when the methylation is higher. And you'll see that our beryllium disease folks tend to have the more extreme, sarcoidosis in between. We've continued to do this work, and we're continued to even take some of our folks with beryllium disease and hope to move soon into sarcoidosis to look at these patterns with time frame from culturing the cells over time. For beryllium folks, we can stimulate them in a culture over 24 hours. Sarcoidosis, we can develop these granuloma-like structures and see if we're finding some differences that are going across both of these groups and how the epigenetic regulation may be the same or different. Our original hope was maybe we could find a fingerprint of exposure. We also looked at trying to define the antigen, and Andrew Fontenot and his group, along with ours, looked at this peptide positional scanning where we just changed the amino acid. And I'll just tell you the long story is short, that we found the CCL3. It's a chemokine that could actually recapitulate an antigen. So this is a self protein. It's one that we know actually starts the innate immune response. So it can actually, maybe beryllium begins to stimulate the immune response, and then through this process can, in some individuals, go on to develop a granulomatous response. But again, what this tells us is beryllium is really resulting in an autoimmune disease. And so I think that's super important. We've used the same approach in the sarcoidosis cases who have this DRB10301, Lofgren's cases from Sweden, and actually found an Aspergillus nigelans peptide that seems to stimulate the immune response. And what we found was, even in our cases of non-Lofgren sarcoidosis who have this HLA-DR3, we found elevation or an immune response to this Aspergillus nigelans, and a transgenic mouse that seems like it recapitulates some aspects of the immune system. So hopefully I've shared with you that the development of granulomas are quite complex, and that we are really learning information from one disease that has implications for the others. This is a nice review that Wonder Drake wrote recently. You know, again, we think that the lung is a little bit of an ignorant organ, and the granuloma is really trying to wall off something. It may or may not be present as time goes by, and there may be other factors that can implicate it, some of which people are continuing to look at, for example, metabolic factors, other exposure factors, and that really clinical clues are critical to define whether these are diseases of known or unknown etiology, as well as hopefully for us someday to define more of those diseases of known etiology. Again, exposure matters, higher dose likely is important, and there is this complex exposure, genetic, time, and other factors that impact disease. So with that, I want to acknowledge a number of my collaborators across the country, as well as our funding sources, and I'm happy to take questions.